You're watching 12 WKRC TV, a new generation of news. 12 Newsmakers starts now.
Good morning and welcome to Newsmakers. With the exception of Social Security, few issues stir more passionate discussion than health care. The creation of the health maintenance organizations, HMOs, has markedly slowed the growth in the overall cost of health plans in the past decade. But many people find that their employers are shifting more of the cost to the employees, making the cost savings seem to evaporate. And doctors complain they have lost the power to make the final decision about what tests and what procedures are necessary to faceless bureaucrats at distant insurance companies. That kind of talk, in turn, scares the heck out of patients. Last week, United Healthcare, the country's second largest health maintenance organization, made a policy change that very well might set a pattern for other health insurance companies. Rather than insurance managers reviewing and possibly overruling doctors' decisions, doctors will have the final say on what care is necessary for their patients. This change does not grow so much out of some set of idealistic moral principles, but the realization that it offered a better way to contain cost. United Healthcare claims that the new policy, called care coordination, will be more cost-effective, and rather than spending hundreds of millions of dollars each year to review doctors' decisions, the company is returning decision-making to the doctors. To discuss the significance of this announcement and, more importantly, the larger issues facing healthcare, I am joined by two people. John Sinclair is a healthcare consultant with the William M. Mercer Incorporated Company. James Tomaszewski is a vice president and chief operating officer of the Alliance Primary Care Practice, a group of 177 internists and primary care physicians. Both received their masters in hospital and health administration at Xavier University. And if I didn't say that last sentence, Ida Schick would have my head over at XU because she recommended both of you. Welcome to Newsmakers.
Thank you.
Thank you, Dan.
Let's just start out, John. How significant is this United Healthcare? All the TV stations, including us, the newspapers, all ran with it as a big deal. Is this a big deal?
Really, from our perspective, we're seeing this a great step in the right direction. It's fascinating how the managed care organizations, besides United Healthcare, have also jumped on the bandwagon to try to react to this. And it's fascinating to see the steps that are being taken now. I think it's also going to help the patients as well.
And what about that, Jim? From a patient's perspective, does this significantly change? Because there's this aura out there that my doctor cannot make a decision for me, but somebody who isn't a doctor and who I'll never meet and who he or she may never meet is making that decision.
Right,
does
Dan.
It change my situation?
I think it does, fundamentally. I applaud United Health Group's stance on this. They won't be the last. Others will look at this and say, was this truly a economic decision, or was this truly a quality of care decision? And I think it's probably both. I think United has looked within their own structure and said, you know, this is an effort. When we talk about managed care, how are we managing care? Well, we're managing it by second-guessing physician decision-making in clinical protocols. And maybe that's not the best role for a health maintenance organization, because they're primarily a financial organization. Care is delivered at the physician office and in hospitals around the country.
My understanding is that what United wants to do, and what I presume other HMOs or insurance companies would want to do as well, is not just say, oh, we're turning it all back over and now we're going back to the old system, but we're putting in place, and I looked at their press release, it's something called care coordination, that they actually want to work with the doctors using their experience over the last decade or so to say, here's the best set of practices. We're returning some power back to you, but we still want to work with you to do that. Is that the correct view of this?
Yeah, I really think it is. I coincidentally happened to go to the doctor yesterday and had the opportunity to talk to my primary care physician, which was fascinating because normally I only get about 5 or 10 minutes with her. But when I told her I was going to be talking about United Healthcare, she went off, gave me a whole 15-minute dissertation on the impact to the physicians. From her perspective, she feels like there's oversight on a constant basis, that she's being dictated to by the managed care organizations, and that 99% of the time, what she's recommended has been taken as gospel from the managed care organization ultimately.
And that's exactly United Healthcare's point. I've seen different percent. I've seen that 99% quoted in the paper, but in their press release they don't use that figure. They just say the vast majority, that they do all these reviews only to approve what the doctor wants to do anyway. It's in a really rare case, so that they're wasting money in effect. You supervise, you work with 177 primary care doctors through Alliance. Do you hear these same sort of complaints? And let me ask it this way. Doctors have traditionally in our society had an awful lot of autonomy. You know, doctors were doctors. You know, nobody questioned doctors or bankers. And you know, HMOs, economic things squeezed them in. Were they over-complaining, or are these real issues?
No, I think they're real issues, Dan. I had breakfast Friday morning with one of our primary care physicians who said, specifically, and it's in his office, it disrupts the operation of his ability to spend time with patients and also to really get the deal done in terms of the financial mechanisms to get it paid for. In his case, he was trying to get a referral to an orthopedist, and the procedure had been done. This is 8 months later. A challenge comes from the managed care organization saying, we're not so sure we want to pay this. We don't think it was appropriate. Where does that put the patient? Where does that put the physician? Where does that put their relationship? And the conflict then erupts between, you know, the negative side of managed care compared to the proper delivery of care by the physician. Our physicians, you know, when they joined Alliance Primary Care, had hoped, moving from their private practices, some of this burden would be lifted.
Because they would have a group that could speak for them.
Right, and clearly that hasn't happened 100% because the pre-authorizations, the pre-certs really come back to the individual office and practitioner. So that didn't work out so well.
Yeah, just before, Jim, you mentioned that some of it might be a decision because of an examination of what really works, what's the best practice. Secondly, what the economic benefit might be. Can I throw in a third one here? Is there a political concern? Is there a political awareness of HMO and insurance companies that we better do something or the politicians are going to step in on this and we better do it ourselves? Is that a factor?
I would say it's definitely a factor, even though I think the press releases would deny the fact that this was the primary driver. It really puts the ball back in the court of the physicians and says, here, physicians, the responsibility and liability is yours. And it's a first step to be able to absolve themselves of the threat of litigation that's pending right now.
Let's talk about, you know, beating up on HMOs has become sort of sport. Can we talk also from your perspective as a consultant who deals with lots of people in healthcare, as someone who works with lots of physicians, what are the good things that maybe we tend to forget that have changed over the last decade maybe because of HMOs? What are the positives here?
Oh, I think there are many, many positives, Dan. I think you know, the whole concept of managing care is a positive. There's both an art and a science in clinical care delivery. The science has to do with the knowledge base of medicine, the technology that's out there to make people better, to fix people when they're sick and when they're ill. The art side of it is how each physician uses that science to get the job done. And that's where all the variation is. And that's where managed care has said, wow, if we can channel the variation, if we can create protocols, if we can
put limits on the variation?
Put paths, right, to get the same job done, we can not only deliver effective care, but also do it cost effectively. The Health Alliance has taken that model, that approach now in the last several years, looking at the difference between, you know, we're consolidating services, but really now the big effort is in how we really manage each individual's care from preventive care all the way through the continuum.
You know, one of the things, again, that this care coordination announcement from United Healthcare raises is that physicians will have access to their data, their computer information about how patients with different problems have really fared under different treatments. is that real? I mean, is that, again, over the past 10 years, when you were saying before, a lot of doctors in their own single practices out there, now they're more clustered into groups. Has that given individual doctors more power of knowledge, and they know what works and what doesn't?
Now, those who know me well know my philosophy on life, and that is egos and economics drive a lot of decision making. And,
well, there aren't any egos in medicine, are there?
I'm going to write a book about that when I finish this job. But at any rate, truly, when payment systems were a lot different, a lot of these things didn't enter the. I mean, physicians still delivered good care, but the variation was broad. Now we're talking about cost-effective delivery of the same level of care. In the Alliance Primary Care, our physician organization has taken the position that we need to do some things that keep our ranks in order. And for an example, we have a care coordination effort underway, led by Dr. Tim Freeman for the Health Alliance, that's looking at all of this issue of appropriate lengths of stay in the hospital. Yeah. We've got another issue looking at diabetes management, very, very intense. We've got a diabetes nurse clinician that's out talking with patients, talking with physicians on how to best deliver diabetes care. And we'll have results on that in the
next
next
few months. Sort of thing an individual doctor would never have been able to do except sort of talking casually.
Right.
You know, John, one of the things, though, that has been mentioned is new technologies, new medicines become available, et cetera, et cetera. All these things are very expensive. Isn't there ultimately, though, some issue here from a societal point of view about distribution and limits on health care, that all of us, there aren't enough dollars to treat all of us with the maximum best health care available. And somebody has to make that decision, and nobody wants to make it. Is that part of what's going on here?
To some degree, but I'll first agree that in the grand scheme of things, I could create a benefit plan that covers absolutely everything. It could cover my toothbrushes and my toothpaste tomorrow if we wanted to, but somebody has to bear that cost. And historically, it's been the employers and the government. And now the government's waking up and saying, we, Medicare, can't afford to continue to subsidize this, and the employers are starting to see costs increasing and saying, we can't afford it either. So there's some built-in rationing already based purely on the funding.
And part of what HMOs did, in effect, I think, is that they did some of that rationing. Is that correct?
It's not just HMOs, but insurance companies by their very nature, as soon as they start to take risk for providing some level of services and saying, we're going to pay for certain things, we're not going to pay for others, that's rationing.
Okay. You know, from a patient's point of view, Jim, and you know, the doctor, you work with all these doctors, the patient's point of view is, when I'm sick, I want the care. I mean, that's just the way I am.
Absolutely.
And I mean, realistically, is a lot of this sort of education of all of us about what's realistically possible. And I think I've seen lots of statistics about what percentage of the healthcare dollar is spent in the last 2 weeks of life. You know, we're trying desperately to save people who really, I mean, let's face it, death is part of our existence, and you just can't stop it. Do we have to get more realistic and help all of us understand what the limits are here?
Yeah, I think you're exactly right. That's, you know, healthcare is not a buffet line anymore. Maybe it used to be. Maybe you could go back and get as many desserts as you wanted, but no longer the case. Now you got to pay. Somebody has to pay.
Well, somebody always had to pay, but in the old days, it wasn't. The way you rationed was, if you had money,
right,
you paid, and if you didn't,
right,
you didn't get it, right?
Right. And education is clearly a vital piece of it, not only to the patients, you know, the physicians, and I think the insurance carriers are learning too. You know, they have a responsibility to manage the financial piece of this, but the clinical care part really comes back to the nurses and the physicians, the care providers that are doing this. Patients need to know also what are the options available. The internet, my gosh, more patients today have access to information on the internet, and they're getting up to speed. And they can call an HMO and say, wait a minute, you can't deny this. Here's the literature.
John, and let's just play with that for a second. I've got less than a minute here to go. Is that a positive or a negative, though? Information unfiltered, just sort of running around out there. You know, you're on the internet, oh, I got this problem, I want this. And I see all these commercials on TV with all the disclaimers at the bottom. They're prescription. They're trying to sell us prescription stuff, which you can't go to the drugstore and get. We got to go to the doctor and pound them over the head for. Is this education?
Well, the access to information is an exciting opportunity. It's not dissimilar to the stock market. It's a free market. The more information we have, the more informed choices we can make as we pick our stocks. Now, certainly there is a role for the SEC and others to dictate that, and that's right. But certainly the access to information has got to be a step in the right direction.
It's a step in the right direction, but who has responsibility for helping us individuals channel that? Is the individual doctor? Is it the healthcare groups? Is it the hospitals? Is it the insurance companies? Or all of the above?
I'd say it's all the above,
I
but
vote for all the above.
To a large degree, a lot of what we started this conversation around was United Healthcare and managed care organizations seeking a role for themselves, and they're seeking to be that intermediary who will channel the information.
Thank you very much.
Nice tie back.
Yeah, nice tie back at the beginning. All of us Xavier grads do that. Thank you very much for being here this morning, and we may come back to you as this whole issue keeps evolving over the next few years.
Thank you, Dan.
Stay tuned. After the break, I'll be joined by Stephen Adamowski to talk about the reorganization of West Side Cincinnati Public Schools. Welcome back. Last Wednesday, the Cincinnati Public Schools announced the details of a plan that will reorganize schools in the center of the city and the west side of the city. The key element of this plan, which has already been implemented in other areas of the city, transforms several kindergarten through 6th grade elementaries into K through 8th grade schools, eliminating middle schools where a lot of discipline problems are focused. 9 schools will make the K through 8 change. The Cincinnati Academy for Math and Science, CAMUS, at Quebec Heights will close as a magnet school and reopen, the school building will reopen as a K through 8 neighborhood school. In the West End, Porter and Hayes will be consolidated into one K through 8, and Washburn Elementary will close. The school board must still approve this plan. The proposal directly affects 15 schools and about 7,000 students. And as always is the case, changes like this create controversy and discussion. I'm sure you've heard some of it on our news and in the papers. To talk about the proposal and its implications, I am joined by the school superintendent, Stephen Adamowski. Stephen, welcome back to Newsmakers. At some point, we're going to endow a chair here for you.
Yeah, always great to be here.
And it's good to always have you here. First off, is this a brand new plan that's being addressed to the west side, or is this part of a larger plan?
Well, this is actually the 4th and final phase of a 4-year plan. 4 years ago, the Cincinnati Board of Education set the course to gradually transition our system, which was largely organized K-6, 7, 8, and 9, 12, into a system of K-8 neighborhood schools. This has been done in three previous phases, which has affected the other 3/4 of the school district already.
So other parts of the city have already had this
already, and some for several years, of course. Those that were in the first phase. This last phase affects the West End and a portion of the Central City schools. One of the I think distinguishing characteristics about it, though, is that it also attempts to create neighborhood schools on the West End in response to a great deal of parental input and community council input. One of the areas in particular where we have heard from the voters, I think consistently, is in the Price Hill area. We do not have a neighborhood school in Price Hill. And we have, for the last number of years, a good number of years, probably the last decade, been busing large numbers of Price Hill students across town, across the Mill Creek, into Center City schools, and so on. It's amazing. I had several letters from Price Hill residents who said they were voting against our school levy because they didn't believe that we were going to do this, that we were actually going to continue with the plan and create neighborhood schools on the West End, and I wish they had opportunity of foresight.
Yeah, well, we can talk about timing maybe in another context. Let's do a couple of things. One, the Quebec Heights School has had a magnet there, CAMUS, which is Math and Science Magnet School. Why is that program closing? Is this a decision we're closing magnet schools and going to only neighborhood schools?
Absolutely not. We are preserving and protecting all of our magnets. There are two things that create an exception for Quebec Heights. One is the fact that if you look at the student population there, over half of the student population are students that are electing it because they live in the area. And again, this is representational of a demand for a neighborhood school in Price Hill. The magnet program itself, which is devoted to math and science, has not had higher math and science scores than our other schools.
And they came up in the test results last year, right?
So, I mean, I think there's every compelling reason there for that school to convert to be a neighborhood school. We don't have a compelling reason in terms of student achievement to forego that in favor of a magnet. Now, however, this plan also strengthens our magnet system in that it allows the Clark Montessori, also on the west end, to move to the current Dater site. We have a waiting list, had a waiting list at the beginning of this year of 124 students who could not enroll at Carson. There was just much more demand for Montessori education than we could meet. Moving to the larger facility will allow us to meet that parental demand. Now, that will also allow us to use Carson as a neighborhood school. So now we have two neighborhood schools on the west side of town, and I think it's a double win of creating a neighborhood school and also strengthening and expanding an area in which we have parental demand for more Montessori education.
The other key issue here, I think, is, and whenever a school closes, it becomes an issue. Washburn will be closed. It's in the West End. Was that part of the plan, the facility study plan? Was there anything new about this? Was this a surprise to anybody?
Well, our facilities plan anticipated that there would be at least one school in the west end of the east side that would not be necessary based upon the number of students once you created or once you eliminated the busing in of all the Price Hill students. Now, we've taken a very serious look at this. We've got three schools that are in very close proximity to each other. Heberly, the Hayes Porter complex, which was actually two schools, is functioning as two schools now, and Washburn. If you look at, there are many children in that area that could walk to any one of those three schools. The recommendation on Washburn is really a function of its condition and the amount of money that would have to be spent there. It's on a very small footprint as opposed to Heberly, which is larger, and Hayes Porter, which is in the best condition and much larger. And we feel we can do the best good for the greatest amount of students by focusing renovation dollars in those two buildings.
I only have 2 minutes, so I'm very aware of time here. One of the things that always happens is that when a school closes down or these sorts of changes are made, people say, I didn't know it was going to happen. I didn't see it coming. And Shirley Colbert in the West End, who has been a leader in the West End for a long time and is a friend of mine and who I really trust, says she was on the advisory committee at Washburn and had no idea this was coming. Where's the breakdown there?
Well, I have a great amount of respect for Ms. Colbert. She is an employee at Washburn, as an instructional aide there. And that is, I think, in general, a very good staff that is working very hard and doing very, very good work. Our conception of this over time and the way we have operated with this in terms of further phases is to make known to the board relative to the timeline that we have for school closings.
The Board of Trustees.
No, the Board of Education.
Board of Education, I'm sorry.
That here is the proposal for the next phase. And once presented to the board so that they have knowledge of it, then we have systematically worked with the LSDMCs, which are our local school councils, in order to refine this relative to streets and how it would be handled, and if there are better ideas about it. But we try not to be in the position where We are working with an issue like this in the community where, word is spreading and our own Board of Education is not aware of it.
Okay, I've got less than 30 seconds, so real quickly, one of the criticisms during the campaign was, though, the school board, school system has to be better about communications. Is that something that you agree that you have to be better?
We have an effort underway, as you're probably aware, headed by Rick Williams on our school board, to define and refine and change the way the board engages with the public. And there may be some changes as a result of that.
Okay. Thank you for being here this morning.
Thanks for having me.
Good luck. Thank you for making Newsmakers a part of your Sunday morning. Join us again next week for a discussion with the women and men who are shaping our community for the future. Advisory committee at Washburn and had no idea this was coming. Where's the...
Which is in the best condition and much larger, and we feel we can do the best good for the great...